Okay, well, it's 12:01 Eastern Time. I guess we'll go ahead and get started. And this lecture is Dreamland in the ED, and there's three presenters. The first presenter is Dr. Isaacs. He's a professor of emergency medicine at Zuckerberg San Francisco General Hospital, and he's the chair of SAEM Ethics Committee. The second is Dr. Jacob. She's an assistant professor of emergency medicine and director of the Medical Toxicology Fellowship at Rutgers, New Jersey Medical School. And last doctor is Dr. Maloney. He's assistant professor of emergency medicine at Case Western Reserve. And he's also the medical director at the Cleveland VA. So I'll turn it over to you.
All right. Thank you. We're going to be talking about ethical issues in the management of patients with opioid use disorder in the emergency department. This is Dr. Maloney. So, one second. This is multiple ethical pitfalls. Right? A lot of OUD patients can be challenging on many levels. Many of them are medically complex, both because of chronic medical issues and chronic pain issues, as well as possible sequelae from their opioid use. There's frequent psychiatric comorbidities. So a lot of patients have depression or concomitant personality disorders that can make managing their opioid use disorder from both an acute and a long-term perspective difficult. And they also frequently have issues with access to care. As we see with many of our patients who are on the margins of society, many of them have some socioeconomic disadvantages of our other patients who don't have opioid use disorder. And then additionally, other issues that patients may have, difficulty with holding a job, criminal records that may prevent them from gaining employment and access to insurance, can also limit their options for treatment. Many physicians also carry negative preconceptions about the patients. Although this does seem to be changing, there's still many, even in healthcare, who look at addiction as a personal choice and not a disease that may be outside of the person's control. They may have had frequent negative interactions in the past with patients with addiction. They also may look at everybody, paint everybody with the same brush, so to speak. They may see every opioid use disorder patient as the same and not view each person by their individual circumstances. Gina?
Okay, thank you. So, as we all know, naloxone is a drug that reverses opioid overdose, but there is some debate about the extent and availability and utility of the widespread distribution of naloxone. So some of the controversies that do arise are, so one, does it encourage opioid use? Some may believe that naloxone can encourage opioid abuse by minimizing those consequences and risks associated with using opioids, versus others that believe that addiction is a disease with a scientific basis to support this, and naloxone is a treatment for a disease, just like we treat other types of other diseases. Two is, does it save lives? So we know that when the naloxone is administered to patients with respiratory depression, it can. At this point in time, there is some conflicting studies regarding mortality in certain populations after the initiation of naloxone distribution programs. But this research is evolving, and there are many confounding factors that need to be taken into account when we're interpreting this type of research. So another controversy is, should naloxone be allowed to be bought without a prescription? So proponents believe that if naloxone is available without a prescription, it is more readily available to those who really need it, versus those who believe that availability can encourage drug abuse by minimizing those risks and consequences. So 4 is, should money be spent on drug abuse and prevention rather than reversing overdose? So while drug abuse prevention and education are important, it's really not enough to stop the opioid crisis. And again, it really goes back to the scientific basis for addiction being a disease, and we need a way to treat these patients. Another controversy is, should we be using resources for distributing naloxone versus treatment of addiction? And while treatment of addiction truly is, it's paramount, it's still a very difficult disease to treat. And it's really not enough to stop the opioid crisis and the resulting deaths that we do see. 6, I would say, is another controversy is, should all parties that administer naloxone be required to participate in naloxone training programs? So there is concern that those that are administering naloxone need to be trained first to identify how and when to administer naloxone and how to monitor these patients. But most states do not have this requirement. Next slide. So another controversy is whether it's cost effective. So this brings us to health outcomes measures, such as quality adjusted life years, where 1 quality adjusted life year is perfect health and 0 is death. So there have been a few studies that have looked at this. One was from the University of Toronto, where they looked at naloxone distribution and the incremental cost. And they found an incremental cost of about $438 per basically quality adjusted life year gained. So this will differ depending on the age of the patient. And if you're looking at this purely from a cost effectiveness standpoint, it increases the younger the demographic. But again, these are very complex issues, and lots of ethical issues to consider as well. Next is factors to consider where naloxone should be distributed. So I think one very important question to ask at that point is, how likely are certain individuals to encounter those with high rates of opioid abuse? So many will agree that police, family, friends of high-risk individuals, should have access to naloxone, or even like prisons, rehab centers. Librarians in some cities have access to naloxone. And the others will say even institutions such as bars or clubs where they may encounter high rates of opioid abuse should have access as well. Another controversy is, should those that receive naloxone be mandated to receive drug education and have an opportunity for detoxification? So at our institution, when patients do receive naloxone, they are brought to our ED, and we have peer navigators who are peers that have been successful in the recovery process to come speak to our patients. And many times when we work very closely with the addiction service, we'll have a warm handoff with the patient there present to really take that extra step to ensure that they are able to and will follow up at the addiction clinic. Next is, should we be instituting emergency department naloxone distribution programs? So at our institution, we do have a naloxone distribution program, and naloxone kits are offered to patients that present after an opioid overdose, and we offer it to patients or friends or family that may be with the patient as well. And our patients do get education regarding the appropriate use of intranasal naloxone as well. And lastly, there is the question of, should we be using resources to expand naloxone distribution programs, or should more of the onus be put on the prescribers and reducing opioid prescribing? And I think reducing opioid prescribing is very important. And so this goes back to using things like the prescription drug monitoring system, using opioid sparing modalities whenever it is appropriate. So at our institution, we also have opioid sparing guidelines for patients that present in pain. So I think there is a lot of onus on us as prescribers for the appropriate use of opioids. Thank you. Go to the next slide.
So some ethical pitfalls to naloxone distribution. So it does seem to reduce deaths. Speaking just locally with our experience over in the Cleveland area, there was a definite drop in death rate among people who had received the naloxone distribution kits. We actually had several people coming back for refills. And then again, this is controversial in terms of determining the impact, but there are some patients who, after a near-death experience from an opioid overdose, that will provide the motivation for them to make a decision to enter treatment. So this isn't simply saving somebody's life for them to overdose again, but there seems to be a certain percentage of these patients who will, in fact, take the moment that the naloxone brought them to decide to enter into a treatment program, and therefore reduce the number of opioid addicts. We've had several successful ED naloxone distribution programs. When I was at Metro Health in Cleveland, we started the first one in the area. There's several more after that. Reluctance by providers is probably one of the biggest things that can impact a naloxone distribution program. Different comments that have come out is, why are we giving them naloxone? They're just going to go out and overdose again. We're not treating their addiction by giving them naloxone, which is true, but our goal isn't to treat their addiction. Our goal is to save lives. They'll be more likely to overdose if they think they have naloxone to save them. And that at least doesn't seem to pan out. At least there's been no conclusive research that shows that patients feel that they can take greater risks with their opioid use if they have naloxone available. Other comments are, well, their friend will never give them naloxone. Why would an addict give another addict naloxone? And that also doesn't seem to be the case. We've actually had several family members who have requested naloxone. And although, again, laws vary state by state, in our state, you're actually allowed to fill out a prescription for a family member to pick up naloxone, because in several of the deaths we had were at home, and having a family member have the naloxone kit, it helped. Going on to the other subject of controversy with management of ED opioid use disorder, ED buprenorphine. Although the number of EDs doing buprenorphine seems to be a little bit smaller than those doing naloxone distribution programs, that number is growing. They've had several successful models. Yale certainly has been a leader in this. These programs generally involve induction in the ED. They generally have everything except for an outpatient follow-up plan. And most of them are not a one-off giveaway program. The patient has to be willing to follow up and has to be interested in entering treatment, not just coming in to get buprenorphine for treatment of withdrawal syndrome symptoms. And there's similar problems and pitfalls with provider attitudes. His comments following is it's treating one drug with another, although for certain patients, medication-assisted treatment allows for much more successful maintenance of sobriety and reduction of relapse. There are people who think that this shouldn't be something we're doing out of the ED. One comment that's so frequently, we actually have a ED buprenorphine program through the VA, was we'll have a line of people showing up at the door for buprenorphine, which again has also not panned out. If you have a program set up with parameters where you're giving it to people who are interested truly in induction and not people who are looking to come in and get a quick dose of buprenorphine for withdrawal syndromes, then that doesn't create an incentive for people lining up. We've actually had a relatively small number of people coming in looking for buprenorphine induction. There is concern about people selling and diverting the buprenorphine. That is harder to track. We do have patients who go into addiction treatment programs, and obviously their use of buprenorphine is monitored with standard urine drug screens. The fact that some patients may divert it does not make it unethical to provide it to the large number of patients who are legitimately looking for treatment of their addiction. Dr. Isaacs?
Thank you. So I wanted to just briefly run through a case to kind of bring up some major points and perhaps give an example of how to think about this. So this is a case that probably many people have seen, a young person who has a witnessed overdose, brought in by paramedics, was given naloxone in the field, accompanied by his partner who witnessed it. And then of course, after being in the ED for 15 minutes, is starting to get dressed and wants to leave. Go ahead, next slide, please. So the the key question, the reason why we have ethical principles or ethical conflicts is because there are really compelling reasons to do exactly the opposite thing. Do we kind of work to keep the patient in the ED because there is a risk of morbidity and mortality, or do we respect their autonomy, allowing them to leave? And the problem is that there are really good arguments to do both things. Next slide. So the first kind of point I wanted to just make is to start thinking about the terminology of AMA. There's now a movement to suggest that we should start using patient-centered terms like a patient-directed discharge. This is still a little uncomfortable for me, but as we are thinking about patient-centered language, actually we should probably start using that, as AMA is a stigmatizing term and may feed into the bias that we have against patients with substance use disorder anyway. The next kind of major point that I wanted to make or think about is related to capacity. The capacity is a situation-specific decision. Do they have the ability to make this decision for this particular situation? And while some people disagree, think you should have standards for capacity that are equal throughout for different situations, I actually subscribe to the philosophy that capacity is different for different situations. So for example, if you have somebody with an MI, a ST elevation MI, and they're hypotensive and short of breath, their capacity to refuse treatment is different than somebody who got their hand caught in the car door and has a hematoma underneath the nail and wants to go home and make sure the dog is well taken care of. You're going to apply different standards to those situations, and so our standards might be different for different opiate overdose situations, and it's really kind of thinking about the benefit for the harm and what really is the risk. And one of the issues that I feel is that the risk is a little bit, we're going to try and be literature based, and the risk is a little bit different now than it was maybe in the late 90s when people were using IV heroin and it was pretty clean. There weren't a lot of adulterants, versus now where fentanyl is at least in a lot of the substances that are being used by our patients. And so how much naloxone did it need? What substance did they use? Is it fentanyl? Is it a synthetic opiate, a long-lasting opiate? That's obviously going to make the risk different. Are they showing signs of pulmonary edema now? Will they have somebody to go home with? And your advice can vary depending on the situation specifically. I wanted to touch briefly on harm as we're sort of out of time. In addition to the morbidity and mortality that may happen from patient leaving as a patient-directed discharge, I also want to think about when we do force people to stay in the ED, there can be injuries from use of force. There are repercussions from a violation of trust in the therapeutic alliance that's violated. If we allow them to leave there, we're missing the opportunity for a substance use intervention, being able to give them buprenorphine, give them counseling, let them give them information for a program. Following a harm reduction model, of course, we are advocating, at least in San Francisco, the take-home naloxone is harm reduction, and that is beneficial. We're out of time. So happy, I think we're all happy to talk about this more with you offline, but appreciate your attention, and I guess we can end now and open it up for questions, or we may need to move on.
Thank you. That was a good talk and very pertinent to, I think, all our practices. I didn't see any questions in the chat box, but I don't know if anyone had any other questions. Well, thank you very much for your time. It was a very good lecture. Thank you.
All right.
Okay, thank you.
Thanks, everybody.
Thanks.
Okay, thank you, everyone.
Thank you.
Thank you.